Hello guys, now we are going to discuss about the medicine updates. Thing has been demanded by a lot of you and every one of you are waiting for this update section. So this will be crisp session, daily session mainly. We will cover each of the topic and subspecialty of medicine and important update in the medicine topic in the last 1 year. Right. So first topic for the day is about the medicine update section in pulmonology section. Right. So we will look into the important practice changing guideline which came within last year. We will look into the important landmark trials or important drug update, right? So firstly, coming to this about this reversed ISHAM ABPA working group clinical practice guideline for diagnosing, classifying and treating allergic bronchopulmonary aspergillosis, right? So this guideline has been published by the body, which you can see logo here. It is nothing but the logo of the body known as European Respiratory Journal, right? And this European Respiratory Journal published this guideline in 2024. Okay, so what is all about? This guideline come from the ISHAM ABPA working group. This ISHAM full form is International Society for Human and Animal Mycology, right? So along with this working group and a daily consensus method, which involves experts from different countries, many countries, it laid forward a goal to provide an updated recommendation for the diagnosis and management of ABPA or allergic bronchopulmonary aspergillosis. Right. Now, this disease is nothing new. It was earlier described in firstly in the late 1950s, right? But there has been a lot of updates regarding it, how to diagnose, how to treat, and how to manage the condition. Very first criteria, which has been used in practice for so many years, was given by Rosenberg and Pattinson. Rosenberg and Pattinson. They give the criteria in the year 1972, right? So they give it in the 1977. Okay, so that was the initial criteria. Followed which it was modified by the Isham group in 2013. Now again there is update of this Isham ABPA working criteria, which is came in this late in 2024. Now what are the important thing or practice changing thing in the guideline? Number one, it covers allergy to any Aspergillus species compared to earlier to only Aspergillus fumigatus allergy to in patient of asthma or cystic fibrosis. Now it covers almost variety of diseases and not only to Aspergillus fumigatus. Now it covers along with Aspergillus fumigatus, it covers other Aspergillus species as well. Okay. And also there is another new terminology described in this criteria. It is about ABPM. What is ABPM? ABPM is allergic bronchopulmonary mycosis, which is caused by non-Aspergillus fungi. So this criteria not only laid about Aspergillus fumigatus, it included other Aspergillus species, and it also not only laid about Aspergillus species, it also discussed about other non-Aspergillus fungi causing similar pattern and presentation. Right. Now, what are the predisposing factors? In old criteria, the predisposing factors were only bronchial asthma or cystic fibrosis. Whereas in this new criteria, we are talking about to expanding it to include asthma, cystic fibrosis, along with it COPD and bronchiectasis as one of the important predisposing factor which may lead to this similar presentation, or even patients with compatible clinico-radiological presentation without any underlying disease. If it all fits into this clinical and radiological finding of ABPA, we can still diagnose this case as ABPA, right? And other important thing in this criteria is about the total IgE value. Okay, so what are the changes in the total IgE value? Earlier criteria said that more than 1000 total IgE level or approximately equivalent to that value was already included in other criteria. Now this more than 1000 cutoff has been lowered to more than 500, right? It is lowered to more than 500. So what is the importance of lowering the criteria to more than 500? It helped in diagnostic sensitivity. Now earlier when it was more than 1000, sensitivity of this diagnosis of total IgE was around 90%. Currently, when we lowered the bar of IgE level to 500, diagnostic sensitivity have raised up to 98%. Okay, so that's the benefit of this lowering the threshold of total IgE level. Next, this criteria also discussed about uh, about IgE and IgG specific testing. IgE and IgG specific testing. What does it told? Earlier, it included, remember guys, it included skin test for aspergillus fumigatus specific IgE or IgG recipient antibodies. Now, their value has been laid to it. Value is now currently there is value which is essential criteria. It is aspergillus fumigatus Ig level more than 0.35. Remember this value 0.35 has been included as essential criteria or a positive skin test, which is also the part of the earlier criteria. So along with skin test, we have laid a value of the Ig level, titer value, beyond which we can consider it to be positive test, right? Along with this, there are some additional criteria raised regarding IgE and IgG level. So what are those additional criteria? This additional criteria is two of the following: either IgG level more than 27, IgG level more than 27, or eosinophil level more than 500, or CT radiograph feature suggestive of this ABPA. So additional criteria is IgG more than 27, or eosinophil more than 500, or CT feature suggestive of ABPA. So any two out of the three is considered the additional criteria, right? Okay. So what was the earlier eosinophilia? Earlier eosinophilia was considered when it was more than 500 or 1000, and based on the scheme, different schemes, some scheme considered it to be more than 1000, some schemes considered it to be more than 500. New criteria retained more than 500 cell per microliter as one of the additional criteria to it, right? Okay. So another thing is that we have ABPM criteria, that is allergic bronchopulmonary mycosis criteria, where fungus specific IgE plus total IgE more than 500 plus two of the following: IgG or eosinophil more than 500, or positive fungal culture and compatible imaging was considered. Okay, so this is all about the update in brief about reversed ISHAM ABPA criteria. Also, beside this, there are some proposed changes. Now, look, in the earlier ISHAM working group, there are 6 stages, right? 6 clinical classification of staging. Now, the new one modified it to 5 stages. This modification of 5 stages is to decrease the complication associated with classification, right? Now, the 5 categories which are currently present in this ISHAM working group criteria of 2024 update are the acute, along with we have called it something known as response. Then we see the remission stage, we see the treatment dependent ABPA stage, as well as the advanced stage. So these are the 6 stages which are currently in practice. One is acute stage, then response stage, then remission stage, treatment dependent ABPA stage, and advanced ABPA. Which of the following is removed? We have removed about asymptomatic stage, we have removed exacerbation stage, and glucocorticoid dependent asthma stage. Okay, so these are the six number stage which is currently reduced to 5 categories. Okay, all right. Now regarding the clinico-radiological finding part, now earlier criteria only discuss about fleeting pulmonary opacities, central bronchiectasis, and mucus plug, right? So earlier criteria only talk about fleeting fleeting pulmonary opacities, one thing. Then it also discussed about central bronchiectasis, and mucus plugging. These are the three things that was described, right? Now, current criteria, it includes CT finding of this old one. Along with it, it included something known as high attenuation mucus, or or along with it, if all of this satisfy criteria, even fleeting opacities on X-ray itself qualifies for the radiological finding for ABPA, right? Okay. So here you can see in this image, this is nothing but high attenuation mucus. Okay. Okay. It satisfies the criteria. Even the fleeting opacity on the X-ray also will also qualify for the diagnosis. Now here, as you can see, it is the finger in glove appearance, which is typical, very typical of the presentation of ABPA, right? Now taxonomically, this ABPA is classified into 5 subtypes, and what are those? Those taxonomical classification of 5 subtypes are S for serology positive only without bronchiectasis, serology positive minus bronchiectasis. Then we have B subtypes. B subtype is that one which has positive bronchiectasis feature. We have MP subtypes. MP is nothing but mucus plug. We have HEM subtypes. HEM is high attenuation mucus, and we have the old one which was present in earlier criteria also, that is CPF, that is cystic fibrosis patient, fibrosis patient. So these are the 5, 1, 1, 2, 3, 4, 5 subtypes, taxonomical subtypes of ABPA. S subtypes where serology is only positive but bronchiectasis is absent. B subtypes where there is bronchiectasis present, and CPF is cystic fibrosis pattern, MP is mucus plug, and HAM is high attenuation mucus. Okay, all right. So let's see the difference again. So based on the differences between previous criteria and 2024 ISHAM update, what are the practice changing guidelines? Practice changing guidelines are, first of all, regarding total IgA threshold. Total IgA threshold has been changed. Previously it was 1000, now it is currently more than 500. And what does it help? It helps to increase the sensitivity. Sensitivity has increased more than 98% with this change. Now, predisposing condition earlier was only asthma and cystic fibrosis. Even it was said that if the patient was COPD, do not consider it to be ABPA. But the present update includes COPD, it includes bronchiectasis or imaging only changes suggestive of ABPA, even without any past history of any respiratory illness. Okay. Earlier, essential Ig was only to Aspergillus fumigatus specific. Now it includes other Aspergillus species as well as there are criteria laid for mycological other illness apart from non-Aspergillus species, right? Okay. So in additional criteria, IgG and precipitation were only for skin prick test. Currently, value and titer is given to it, like IgG more than 27, eosinophil more than 500, or CT X-ray finding. Remember, any 2 out of the 3 is required currently when the new criteria. Okay. So what are the key updates? If you emphasize them again, we have lowered the IgA cutoff. IgA cutoff lowering has improved early detection. We have included COPD and bronchiectasis, which broadens the applicability of this criteria of different disease subgroups. There is objective IgG level and clear image criteria, which is standardized method. We have introduced ABPM entity for non-aspergillus allergic mycosis, and staging has been simplified. Earlier it was 6 stages, currently these are 5 stages. 5 stages enhances the clinical usability of the criteria, right? So overall, this criteria is more sensitive and inclusive, it reduces missed ABPA cases. It provides a clear algorithm pathway. So what test needs to be done, how to do. So first check the Ig level, then check the CT. Okay. So this algorithmic approach has been possible only because of the revised criteria. Now it enhances the differentiation from ABPM, informing treatment approach and easy categorization. supports management decision. So that's all we need to know about the update part. Now regarding the treatment, so how do you treat? There are multiple level has been laid forward for the management of ABPA. Remember, high dose steroid in the form of oral steroid is the level 1 treatment, and this level 1 treatment high dose steroid can be either methylprednisolone or deflazacort, right? Methylprednisolone or deflazacort, any one of these can be there. And methylprednisolone is given at the dose of 0.4 to 1 milligram per kg per day for around 4 weeks and tapered gradually. Deflazacort is given in the dose of around 0.75 milligram per kg. Okay, all right, and it is given for longer duration compared to methylprednisolone. If at all given, it is given for 4 weeks, for 2 months, then tapered by 6 milligram every 2 weeks until 4 months. Okay, so this deflazacort treatment regimen is little bit of stronger compared to methylprednisolone, and it is level 1 of evidence as it is most rapidly acting. So what are the level 2? Level 2 are oral itraconazole, high dose inhaled steroid, or oral itraconazole voriconazole combination, omalizumab, or nebulized amphotericin B. Okay, so itraconazole and voriconazole should not be given together. It is also been said in multiple places. So if it is given, it should be given separately. Voriconazole doses should be 400 milligram per day in 2 divided doses with a maximum of 600 milligram per day. Okay, so there is something known as posaconazole, which is level 3. It is shown to achieve clinical remission if patient is intolerant to other azole. Okay, all right. So that's all about the management part of about ABPA. Now we are going to the next symptom and update related to the next symptom. So we are talking about pulmonorenal syndrome. What is it? It is a group of disorder with simultaneous pulmono as well as renal involvement. So what are the features of it? Both of those. Among the pulmono, we have diffuse alveolar hemorrhage like pattern, and in renal syndrome we have RPGN like pattern, right? So what are the clinical feature? Clinical feature, it can be hemoptysis, dyspnea or cough, and when you go for chest X-ray or any CT scan imaging, they can have bilateral infiltrates. Okay, bilateral infiltrates can be present. Among the renal presentation, it can have hematuria, proteinuria, or elevated creatinine level, and in later stage can present into oliguria or anuria complexes, right? And there can be systemic manifestation as well. Systemic manifestation in the form of fever, joint pain, malaise, skin rashes, or weight loss, depending on the cause of the pulmonary renal syndrome. So, what are the usual cause you need to know? So, usual cause of pulmonary renal syndrome can be divided into autoimmune causes. Autoimmune causes. What are the autoimmune causes? Autoimmune causes are granulomatous polyangiitis, microscopic polyangiitis, eosinophilic granulomatous polyangiitis, or which we call as Church syndrome. And these are the usual autoimmune causes. We can have anti-GBM causes. What are the anti-GBM causes? Anti-GBM causes is nothing but goat posture syndrome. Okay. Then we can have SLE present as lupus nephritis plus pulmonary hemorrhage complex presentation. There can be drug-induced SLE as well as like hydrolyzine propylthiouracil, who drugs leading to SLE leading to the presentation. Although this is rare in drug-induced variety, there can be some of the infection which can present in pulmonary renal syndrome, among which most common and most famous one is the leptospirosis. Leptospirosis, right? There can be also hantaviral pneumonia. Okay, so there are some paraneoplastic malignancy which can also present as pulmonary renal syndrome. So what are the usual presentation of pulmonary renal? They can be autoimmune, either GPA, microscopic polyangiitis, EGPA, that is Church disease. It can be due to anti-GBM disease. Anti-GBM disease is Court-Pasteur syndrome. There can be SLE which present as lupus nephritis and pulmonary hemorrhage. There can be drug-induced causes, drug-induced like due to drugs like hydrolyzine, propylthiouracil, or sulfonamides or isoniazides, which leads to SLE and present as pulmonary syndrome. Infection like leptospirosis or hantavirus or malignancies with with paraneoplastic syndrome, which can present as pulmonary renal syndrome, right? Okay, so what are the update? Update is regarding one important trial. This is known as Spexivas trial. So this Spexivas trial is regarding the management of those vasculitis, ANCA-associated vasculitis, which is the one of the important feature of this pulmonary syndrome. So how do you manage them? You manage them with supportive therapy, with oxygen, ventilation, dialysis if needed, immunosuppression in the form of high dose corticosteroid, cyclophosphamide or rituximab, plasma exchange if required. And indication is mainly anti-GBM or good posture disease or patient having severe diffuse alveolar hemorrhage, right? And ultimately, we need to treat the underlying cause. Now, this Spexivas trial drilled with plasma exchange and glucocorticoid in severe ANCA-associated vasculitis. And what was the outcome? Outcome is that plasma exchange did not significantly reduce mortality or progression to end-stage renal disease. So, routine use of plasma exchange may not be considered in case of pulmonary renal syndrome. That is one of the very important practice changing guideline. That is plasma exchange is not so much of beneficial in routine use according to this Spexivas trial. Okay, all right. Now coming to a very important topic, a very high probability of being asking in the exam, your upcoming exam, whatever exam you are guys facing, it is about the change of the Berlin criteria to to global definition, global definition of ARDS, right? So this is something of the practice changing guideline for us. And remember, this ARDS or acute respiratory distress syndrome has been defined by a lot of people in a lot of time. Very early we have Murray's definition in 1988, and this Murray's definition of 1988 includes something known as Murray's Murray lung injury score, which was based on X-ray, right? Which was based on X-ray only. Okay. So later on in 2013, a big change was brought forward. Big change was brought forward by Berlin criteria, which has used till date until in 2019 an infection hit across the globe and changing the perspective of ARDS toward this infection was nothing but COVID infection, which make ARDS haywire and almost common in each of the districts of the world, each of the places of the world. So that we need to change the guideline to accommodate low resource setting, for definition and management of ARDS. So this new global definition include guidelines for patient for HFNC. It include guidelines for patient on pulse oximetry. It has advocated the use of ultrasound for chest imaging, and it has applicability in resource limited setting. These are the very four important points in this global definition of ARDS, which helped us to guide the therapy. Okay, so what are the changes that we can see between the new and old one? First of all, let's see what is the old one. Old one, that is, we are speaking about the Berlin. We are speaking about the Berlin definition. Okay, so in Berlin definition, first point was timing. Timing, they mentioned about acute. So acute was within week. Okay, acute was within week, and condition precipitated by an acute predisposing risk factor versus any chronic condition, acute was mostly considered. Secondly, second point was about chest imaging. Chest imaging, which will reveal a bilateral opacity, and for the chest imaging, earlier we considered only chest X-ray CT. USG was not considered. Okay. Now, origin of edema needs to be proven. Imaging in the form of echocardiography might be required to prove that it is a non-cardiogenic respiratory failure rather than a cardiogenic variety. And pulmonary edema is not exclusively or primarily attributable to cardiogenic etiology was recommended for diagnosis of ARDS. Following which, we need to classify ARDS between mild, moderate, and severe, and this classification was completely based on PF ratio. PF ratio is PO2 by FiO2 ratio. Okay, this PO2 by FiO2 ratio was mainly for high resource setting or good ICU care setting with PEEP more than 5 centimeter of water. Okay. PF ratio of more than 200 to 300 was considered as mild, less than 200 was considered moderate, and less than 100 was considered severe. This is about the Berlin criteria. Okay. Now, what are the update? Update is in this one, this 2024 global definition. So, we have included the ultrasound recommended in the newly added via the 2024 global definition. Then we have something included instead of PF ratio, we have included something known as SF ratio. SF ratio is given by the name of SpO2 by FiO2 ratio. All right. So, hypoxemia was defined by SpO2 by FiO2 ratio. Here, mild, moderate, and severe was classified. Remember, the severe point less than 140 it was considered severe, and more than 235 was considered mild. So, 235 to 315 was mild, then 148 to 235 was considered as moderate, and less than 148 was considered as severe. Okay. Then this global definition also include the condition for resource limited and non-intubated setting. So resource limited we only consider SF ratio, that is SpO2 and FiO2 ratio. PEEP was not required even at all in this, and in non-intubated cases it included HFNC with flow more than 30 liter per minute or NIV or CPAP with PEEP more than 5 centimeter of water. So these are the two new addition in non-intubated patient as well. Okay. So that's all about the update regarding the diagnostic modality in the global definition, right? So as you can see in non-intubated ARDS, we have included PF ratio, SF ratio or HFNC more than 30 liter per minute or NIV CPAP with at least 5 centimeter of water and expiratory pressure. So 5 centimeter of PEEP in NIV or CPAP, okay, or HFNC with more than 30 liter per minute or SF ratio less than 315. Okay. So all of these were included for non-intubated ARDS. All right. Okay. So why this change? This big change was because of practice changing guideline lead forward by the critical care society during the 2019 pandemic of COVID, where COVID related ARDS case was haywire and rising rapidly. Okay. So ARDS has been a controversial topic with disagreement among societies, among big societies like American Thoracic Society or ESICM. Okay. So first disagreement was regarding very important point that I would like to foster about is about the paralysis. Okay. So when to paralyze the patient? So ATS advocates for paralytic agent in ARDS patient, whereas ESICM completely disagrees with it. Okay. Then second point about disagreement was, this is first point about paralysis, second point was disagreement regarding PEEP level. Okay. So ATS suggests a higher PEEP, whereas ESICM doesn't fully agree to it. Now regarding HFNC and NIV, it is the only place where this ASISM body comes into the lead in the picture and takes the lead and led forward the criteria, the new global definition for ARDS. Okay, all right. So, if you see the strategies of mechanical ventilation in ARDS, what are the important change that has been led forward? One of the important new consensus guideline change says to use recruitment to inflation ratio during ECMO session. So, to consider for recruitment to inflation ratio. Okay. So, it is utilized to determine the optimal PEEP setting in patient with severe ARDS who is undergoing ECMO, particularly the VV ECMO or venovenous ECMO, right? It aims to improve the oxygenation while minimizing the ventilator induced lung injury. Okay. So, what do you need to look at? You need to look at recruitment into inflation ratio. That is a new update according to the guideline. Secondly, regarding the PEEP level, PEEP level. So PEEP to maintain alveolar requirement earlier we considered to be a moderate to high PEEP level. Now this thing has been divided into based on the phenotype of the patient, whether they are hyperinflammatory phenotype or hypoinflammatory phenotype. Now in the hyperinflammatory phenotype, it has been found that they may benefit from fluid. So hyperinflammatory may benefit from fluid or beta blocker, whereas hypoinflammatory may benefit from higher PEEP and less fluid. So liberal fluid can be given in hyperinflammatory phenotype. This metric division between hyperinflammatory and hypoinflammatory or phenotype A and phenotype B helps to predict the prognosis of ARDS patient. The question might come in your mind, how do you predict which patient is hyperinflammatory? So obviously the thing there are some of the level, and level is that interleukin 6 level, TNF alpha level, this will be higher in inflammatory cases, as well as there will be bicarbonate level will be low in case of hyperinflammation. So low bicarbonate, which is more practical and practical oriented, you can check the bicarb level in ABG. If it is on lower side, you can consider the patient to be more of a hyperinflammatory pattern rather than hypo. So if it is the hyperinflammatory pattern, obviously they will improve with liberal fluid, and beta blocker. Okay, all right. Okay, so now there is one of the important drug related update in this topic. It is about Gohibic or vilobelimab. This is a monoclonal antibody targeting complement component, and this complement component is given by the name C5a complement, which aims to mitigate the inflammation associated with ARDS. Okay, so it mitigates the inflammation associated with ARDS. It was authorized for use by the European Union in very early in this year only, in this January 2025, mainly for the SARS-CoV patient who has ARDS pattern. Okay, and it has been found if it is used with the patient receiving systemic corticosteroid and invasive mechanical ventilation, it is very good drug. So what is it? It is a C5a monoclonal antibody targeting compound. Okay, and how does it help? It helps by reducing inflammation. Remember the name of the drug? It is vilobelimab. Vilobelimab. Okay, all right. As you can see here in this chart as well. So there are two things. One is the placebo control trial as well as vilobelimab group. You can clearly see there is mortality benefit, good amount of mortality benefit in the both of the arm of between the placebo group as well as vilobelimab, this C5a monoclonal antibody targeting drug. Okay, so when it is used mainly SARS-CoV, ARDS with a high steroid or with mechanical ventilation stage. This drug can be considered. Okay, all right. So now we are moving to very important topic regarding update of COPD. So this COPD update is given by something known as Global Initiative of Chronic Obstructive Lung Disease or GOLD criteria, right? Okay. So there are very significant changes and important changes. First of all, you should know about there are taxonomical classification of this GOLD criteria of COPD. These are G, S, F, and I. G is for general COPD. S is for smoking associated or cigarette smoking associated COPD. F is biomass exposure induced. Like in lot of people in mainly village areas, you may find lot of cases of COPD. But when you ask about smoking, they will deny it. But why there is COPD? Because there is exposure of biomass burning, exposure of fossil fuel burning, or biomass for in the kitchen works and everything. There are a lot of burning of the bioenergy dependency, which leads to the exposure and this form of COPD among them. Another COPD is the infection associated. So this is the taxonomy of COPD: GSFI, G for general, S for smoking, F for fossil fuel or biomass related, and I for infection related. Okay. So there are a lot of practice changing guidelines in this 2025 update for COPD, but most importantly, remember there is something are unchanged too. For example, the definition of COPD remains unchanged. And what is it, the definition of COPD? Remember, COPD is first of all heterogeneous. Remember, this is a heterogeneous disease, and it is heterogeneous lung condition with chronic respiratory symptom. What are the symptoms we are looking for? We are looking for dyspnea. We are looking for cough. We are looking for sputum production. All right. So these are the three important cardinal symptoms of chronic respiratory symptom in COPD, and exacerbation associated with abnormalities of ARDS. So there can be bronchitis, which is the airway inflammation, or bronchiolitis, which means nothing but small airway inflammation, along with alveolar involvement. Alveolar involvement is nothing but emphysema. Okay, emphysema. This cause persistent, often progressive airflow obstruction is same. Okay. Now, this GOLD report, 2025 report, retains the genomics as a pathophysiological cause of COPD, including genetic involvement of particular gene by the name of SERPIN A1. Okay. So this gene was mentioned in previous guideline also. It has been mentioned in this guideline too. Now, what are the important changes? Important changes include given emphasis on early life exposure, lung growth, and environmental trigger related concept. Remember, lung grows till 22 25 years of age. So, smoking exposure prior to the age of 25 years will delay the lung growth and will lead to COPD. Okay. Okay. So beside this, there is introduction of concept of pre-COPD, early COPD, and young COPD in as a tool of a clinical research concept in this GOLD guidelines. Okay. So first of all, let's talk about how to diagnose the case. So diagnosis is based on FEV1 by FEBC ratio. Based on post bronchodilator should be less than 0.75 to confirm it to be COPD. Okay. And pre-bronchodilator FEB and FBC is used for screening. So if the question says about the pre-bronchodilator thing is about the screening, as well as post-bronchodilator is for diagnosing the case. Okay. Now, important thing is that no need to stop bronchodilator before spirometry, which was earlier considered in the earlier guideline, but currently guideline says no need to stop the bronchodilation before the before the uh, before spirometry. Okay. Now, for younger patient, it is difficult to get FEB1 FBC ratio. So for younger patient, they have mentioned about Z score. All right. Okay. So that's important regarding the diagnosis part. Now coming to the very three important concept of early COPD, young COPD, and pre-COPD. So what are those that actually refer? So early COPD refers to the early stage of COPD, right? As the name goes. So what is that? This early COPD starts very early in life and takes a long time to manifest, and it is more of a research time. So this is more of a research oriented term. That is the important thing that you should know. Then remember, mild COPD should not be used as a marker of early COPD. Mild COPD can occur at any age and may not progress, often relating more to symptom than spirometric measures. This mild COPD term. But early COPD is something of a very early origin and along with early spirometry changes. Okay. So, young COPD is something to do with the age of the patient, and specifically we are considering age less than 50 years. All right. And this patient exhibits structural and functional abnormality due to different factors, most commonly because of alpha 1 antitrypsin, due to environmental exposure, or which we call as COPD. F, then there can be family history, or history of admission, early hospital admission. Okay. So all of this can be seen in early COPD cases. Now, what do you mean by pre-COPD? Okay, so what does pre-COPD actually mean? It means to the patient of any age who present with respiratory symptom and structural lung lesions but do not meet the standard criteria for COPD obstruction after bronchodilator use. So, what are the key characteristics among the pre-COPD? Among the pre-COPD group, their number one point, lung capacity remains normal and FEV1 by FBC ratio is greater than 0.7. So, it is not matching the spirometric criteria, although the symptoms are suggestive of COPD. So, this patient should be monitored, as 20 to 30% of those pre-COPD, 20 to 30% cases may transition to obstructive spirometry pattern or FEV1 by FBC ratio less than 0.7. Okay. Okay. While some of the cases of pre-COPD can also return to normal, and transition is most likely seen in active smoker if you can counsel them to smoking, in as well as high BMI patient as well as very low BMI patient, when dietary approach can improve their BMI to the normal and physiological state. Mostly seen in female gendered, obese patient, or patient with multimorbid condition, especially with cardiovascular issues. All of those can be reversed. Okay. Now remember, this prevalence of pre-COPD in general public is around around 7 to 11%. So it is very high of the population. This pre-COPD, this burden of pre-COPD is also very high. Therefore, all of those should be taken with extra caution so that we don't miss out the cases. And even if we get the cases, we can counsel them properly and manage them properly. Okay. Now there is another update regarding preserved ratio impaired spirometry. So what is it actually? It is given by the short form of PRISM in this update. So PRISM continues to be preserved ratio and impaired spirometry. It has been clarified in this guideline. So if a patient post bronchodilator FEV1 by FBC, post the use of bronchodilator is more than 0.7. So the definition is not fulfilling of COPD, right? They fall into the PRISM criteria. Even if their post bronchodilator FEV1 is less than 80%, this patient will require follow up. So among this patient, what we look into? We look into the life essential aids score. So it is based on the following component: diet, physical activity, tobacco, sleep, BMI, blood glucose level, non-HDL cholesterol, and blood pressure. All of these, after monitoring, are assessed and advised the patient to keep in control. And if they have high early life essential aid score, that is, they are keeping it very good control, this prism can turn into normal spirometry. Whereas normal physiology people, normal person, if they have low early aid score or life essential aid score, they turn into prism. From this prism, there is a very high chance for development of moderate to severe airflow limitation or mild airflow limitation. Both of these are feature of asthma or COPD, and this prism group also turns into asthma COPD overlap stages. So that's why understanding of and identification of prism group is very much important. Having said that, let's move into the treatment part according to the GOLD criteria. So currently gold criteria defines population into A, B or E based on the exacerbation and clinical status. What are the clinical status and exacerbation history we take? In history we take how many history of hospital admission in last 1 year. If it is more than 2 or equal to 2 exacerbation or one exacerbation which may lead to hospital admission within last 1 year, nothing but it is considered serious, it is class E. Now, when there is less than one exacerbation within a year or no hospital admission for in last 1 year, considered it is A or B based on MMRC grading. MMRC 0 to 1 is considered as A or MMRC more than 2 is considered as B. Along with MMRC, we also check the CAT score. CAT score more than 10 is B or CAT score less than 10 is A. Okay. So I'm not going to detail of the scoring and MMRC. Obviously, you know. So what is important is that how to classify E, how to classify it as A, and how to classify as B. Once you classify them, you need to know about the treatment. So how do you treat? So this group A needs to be treated with bronchodilator. It can be either SABA short acting or LABA based on the breathlessness, and SABA is used for occasional breathlessness, otherwise usually LABA is used, long acting beta 2 agonist is used. Okay. Group B contains LABA or LAMA. Remember, LAMA is superior than LABA. Okay. Now group B, which is the serious one when there is hospital admission history, they should be initiated with LABA and LAMA to reduce exacerbation, and one exacerbation has been reduced, and if inhaled corticosteroid can be tried, and if inhaled corticosteroid is indicated, which is more than 2 hospital admission or eosinophil count more than 300. So in such cases, eyes closed, you need to use LABA plus LAMA plus ICS. Okay. So this is according to the gold criteria. Now, coming to the follow-up pharmacological treatment, what are the new update in follow-up pharmacological treatment? New update is about something we have discussed about, something known as dupilumab. Dupilumab is added as a biologic for patients with eosinophilia who continue to suffer despite the dose of LABA plus LAMA plus ICS, and if further you check blood eosinophil more than 300 and they are still suffering clinical symptom, in such cases dupilumab is chosen. Okay. Next, if you check the azithromycin, it is preferably used in smokers when after use of LABA plus LAMA plus ICS, there is no clinical improvement, and you know that the patient was a smoker. In such cases, azithromycin can be started. Roflumast is used when FEV1 remains less than 50% and there is chronic bronchitis. In such cases, roflumast is used to for dyspnea management. Okay. Now regarding eosinophil count concept, in any cases, COPD patient needs to be assessed with eosinophil count during follow-up. So you are giving LABA or LAMA. If blood eosinophil is less than 100, continue LABA and LAMA, right? If blood eosinophil is more than 300, you need to add ICS, and you are continuing LABA LAMA again on follow-up. Blood eosinophil is more than 100, then also you need to consider LABA plus LAMA plus ICS. On ICS, if eosinophil remains more than 300, only then you consider for dupilumab. All right. Okay. So for dyspnea, consider LABA plus LAMA or LABA plus LAMA together, and consider switching inhaler molecule or device of the molecule how the patient is taking, and implement or escalate non-pharmacological treatment, and consider ending ensifentrine. Now, specific thing about ensifentrine has not been mentioned. Now, remember this is a novel medication. This ensifentrine is not available outside United States, so very unlikely that this thing will be asked in any of the Indian exam. Remember, it inhibits, but still you remember it inhibits phosphodiesterase 3 and phosphodiesterase 4 together. Okay, so inhibits phosphodiesterase 3 and phosphodiesterase 4, and this ensifentrine, as you can see in the image in the background, it is usually given in inhaled form, mainly currently available in the nebulizer format. All right. Okay. So that's all about ensifentrine. Now moving to the next part about the management of patient currently on LABA plus ICS. Very important thing that I would like to note here is that although ultimately management is about LABA plus LAMA or LABA plus minus ICS based on the load or symptom load or the condition of the patient, that's all. And one important thing which has been included to consider for vaccination in adult COPD cases, and it's very easy. So respiratory syncytial virus vaccination is recommended if age is more than 60, pneumococcal conjugate vaccine 20 or PCV 15, pneumococcal conjugate vaccine 15 or PPSB 23 has been recommended for pneumonia prophylaxis. Annual flu prophylaxis in the form of Influvac has been mentioned. COVID vaccine is mentioned. Zoster vaccine is mentioned. and Tdap vaccine is also mentioned in the vaccination strategy of COPD patient. Okay, all right. Now there are very two important trial regarding this management. So this is a randomized controlled trial which data supports that a single inhaler triple therapy, that is single inhaler based triple therapy of LABA plus LAMA plus ICS reduces the risk of exacerbation and mortality compared to dual therapy. So you can see ethos trial was phase 3 double-blinded trial. It is a RCT, as well as impact trial. It was also a RCT. And what is the benefit of this trial? It found that single inhaler therapy, single inhaler which contains combination of three, LABA plus LAMA plus ICS, is nothing but beneficial to the patient. Okay, so this non-pharmacological intervention that reduces mortality includes smoking cessation, rehabilitation exercises, mainly the pulmonary rehabilitation, giving the LTOT support, long-term oxygen therapy support, non-invasive positive pressure ventilation, okay, and lung volume reduction surgeries. All of those are the non-pharmacological measures that reduce the mortality among the COPD patient. Okay. Now, once we have discussed about the COPD in detail, a very much detailed discussion, now we are moving into something, a very important topic about asthma management. Asthma, which is given by GINA. Okay, GINA 2025, and what update it has given? It has given discuss about track 1 versus track 2. So, what are the key diagnostic update? Remember, asthma is nothing but variable respiratory symptom plus expiratory flow. Okay, so there is variable respiratory system plus expiratory flow in case of asthma. Now this FEV1 variability, peak flow variability, around daily variability more than 10% remains essential in the management of asthma, right? An important biomarker has been discussed in this GINA 2024 update, mainly about eosinophil or functional FeNO. FeNO is an important biomarker, but important thing which has been mentioned is that you should not consider this biomarker solely in the management of asthma, rather clinical symptom has been given as prudent importance while describing asthma in this June 2025 update. Okay. Now remember, don't rely solely on single spirometry. Asthma is a dynamic parameter. Consider repeat lung function testing with bronchodilator reversibility or peak flow monitoring. Now be cautious while diagnosing asthma in smoker because there can be overlap of COPD known as asthma COPD overlap or SU. Okay. So what are the important update? We have given track 1 and track 2. So track 1 is easily preferred. Track 1 is ICS formoterol as needed. So one inhaler for both control and relief, and it is ICS inhaled corticosteroid and formoterol based solution. And this is one inhaler based therapy which is given as an indication as well as a reliever therapy whenever needed. This is step 1. Step 2 is daily low dose inhaled corticosteroid plus as needed plus minus SABA whenever there is requirement. So, reserved when ICS formoterol is not available, this ICS formoterol combination is not available, only such cases track 2 is chosen. Okay, alright. So, important thing that this guideline says to avoid, it says to avoid phenoterol. Okay, this phenoterol was removed due to safety risks, mainly it was associated with arrhythmia or multiple episode of unexplained death. That's why phenoterol should be avoided in management of the condition. Okay, so how do we approach according to both of those guidelines? First of all, let's see the emergency approach. Emergency approach is this: in any case, whenever patient of symptom of asthma comes, first step is to check for airway, breathing and circulation. Check whether there is drowsiness, confusion or quiet chest present or not. If any of those present, start SABA, short acting drugs and oxygen therapy immediately and request for urgent respiratory support, obtain a ABG. Now, based on the clinical status, obviously you need to try and check for worst feature. So, what are the worst feature? If the patient cannot talk properly or talks in simple word, if there is side hunch forward posture, agitated patient, agitated means there is already CO2 narcosis being set up. There is tachypnea in the form of respiratory rate of more than 30. If there is accessory muscle being used, pulse rate is more than 120, oxygen saturation is less than 90, or PEEP, pre-expiratory flow less than 50% of predicted or best. All of those are clinical feature that is required for this in emergency department based diagnosis of severity or classification of asthma, right? In such cases, what needs to be done? Short acting beta 2 agonist, equatorial bromide, control oxygen at the rate of 92 to maintain 93 to 95% SpO2, oral or IV corticosteroid, and considered IV magnesium. That is very important thing. So, in severe asthma, you can consider it as IV, to give IV magnesium and IV corticosteroid. Okay. Now, in mild to moderate cases, for example, instead of word, currently the patient is speaking in phrases. Instead of sitting hunch forward, they are now sitting in lying. There is no agitation at all. That is no CO2 narcosis. Respiratory rate although increased but is not amounting to considered with severe disease, that is it not reached more than 30. Accessory muscle are not being used, whereas it was used in severe cases. There is increased heart rate but it is less than usually 120, and SpO2 on Romier is with 90 to 95. In such cases, obviously short acting beta agonist is given. Along with it, instead of ipratropium bromide, nothing is given, and oxygen is maintained to 93-95 as well here also. Now, if there is moderate exacerbation, only then we consider ipratropium bromide. Oral corticosteroid is preferred, and high dose inhaled corticosteroid to be taken as a standby plan, and there is nothing mentioned about magnesium sulfate. So, magnesium sulfate is the only medication to be given in severe cases, not in case of moderate case. Okay. Now, when this patient come into the triage and you have given initial medication and you are monitoring the patient, during the triage there is continuous deterioration. Continuous deterioration. So, at any stage if there is deterioration, consider it to be severe and reassess for ICU admission, right? Now, in ICU admission, manage according to the ICU planning. Okay. So, let's move into the what to do in primary care. During assessment, check for the symptom of asthma. Consider other causes, risk factor for asthma related death, and severity of exacerbation. Consider worst feature. Okay. So, severity again the same symptom we are checking at, and if there is life threatening causes like drowsy, confused or quiet chest, an urgent requirement is needed. So, we need to transfer to acute care facility in the form of ICU, right? NED. Okay, and while we shift to ICU, we need to give SABA, ipratropium bromide, oxygen, or systemic steroid. Okay, all right. Now, if it is a mild to moderate disease, we get in the primary care setting. In such case, obviously start SABA, prednisolone for moderate exacerbation, and control oxygenation, as we have seen earlier. Obviously, after starting treatment in the primary care, assess response within an hour and continue treatment with SABA as needed. If there is any worsening of the condition, in any case of the worsening, consider it to be severe disease, life-threatening disease, and treatment needs to be done accordingly. Now, once suppose the patient is improving with initial treatment, obviously you should start to assess for discharge. Check for symptom, check for the need for SABA requirement or not, check peak expiratory flow whether it is more than 60 to 80% of personalized best or predicted, check SPT is more than 94% at room air or not, and resources available at home to give care to the patient. So once all of those are reviewed and confirmed, only then we can discharge the patient. Okay. So what is the update regarding the drug in the management of this asthma? It is at TS 2024-5. There is something update regarding a drug known as Frabicitinib. Frabicitinib is an inhaled pan-JAK kinase inhibitor. So this acceptance of an investigational new drug was given by FDA to conduct clinical testing, right? Clinical testing of this applicable pharmacological product. Okay. So Frabicitinib is an inhaled JAK1, inhaled JAK inhibitor that received FDA and IND approval in January 2025. Okay. And it targets patients with asthma inadequately. Inadequately controlling by the standard therapies. Okay. So this is a very recent drug approved. It is only an investigational new drug. It will take time. It will take time to come into the market. So just remember the name. It is Frabicitinib. All right. Okay. So next question, a very important question about the role of aminophylline in acute asthma management. Remember, GINA 2025 does not recommend its use and it is not even mentioned in routine treatment pathway of, of the asthma management. All right. So, GINA is against it. Okay. So, that's all about all the important updates. And the next session, we are looking into the landmark trials or the drugs related to the pulmonology updates. And obviously, we will day by day gradually move into the cardiology section, nephrology section, and different updates, and we'll make it short and brief so that you can revise very quickly within an hour and finish all the updates before your paper for final exams. Okay, so this session will be helpful for anyone, and mainly medicine residents who are giving the final exam within few days currently. Also this will be very much helpful for the NEET PG aspirant who need to boost up their preparation for the 3rd August for the coming exam. Okay, all right, thank you.